Hello, and thank you for joining us. My name is Jenny Pagel-Guile, and I am the Executive Director of the National Pancreas Foundation. The National Pancreas Foundation provides hope for those suffering from all forms of pancreatic disease. We fund research, advocate for better services and access to care, and provide support and education for patients and caregivers alike. We've awarded over 5 million grants as an organization, and we endorse over 180 centers of excellence across the country. We additionally provide programs, education to medical providers, patients, and their caregivers, providing a rounded scope of education and support to our community. There are many ways that you can be involved in the Pancreas Foundation, as well as several resources available online and on demand. We have the animated patient that provides detailed information about the diagnosis as well as the pancreas itself. We co-sponsor Camp Hope with Rebecca's Wish, our first pediatric pancreatitis camp in the country, and we provide nutrition support through our cookbook services and online webinars. All of this information can be found on our website, as well as a listing of all of our active centers of excellence. Across the country, we have over 30 chapters. These are volunteers and individuals who provide support to each other. They also provide grassroots efforts at tabling at local health fairs, providing fundraising support and education. They also sit in on advocacy calls at the local and national level. We would love to have you join us if you are able, or you can start a chapter in your community. Reach out to our staff if you would like to receive more information. Again, we have a full calendar of events, virtual and in person, on our website. We have an assortment of galas across the country. We have patient education events coming up in person, as well as medical professional events. And again, all of our webinars are available on demand online. The best way to stay up to date is to subscribe to our monthly newsletter. We also are on a variety of social media, so make sure that you follow us and share with your community and peers. We would love to have you join us. I would like to introduce Dr. Martin Freeman. He is a professor of medicine and pediatrics at the University of Minnesota and a renowned leader in the field of gastroenterology. He served as chief of the Division of Gastroenterology, Hepatology, and Nutrition from 2009 to 2022, and has directed programs in advanced endoscopy and total pancreatectomy with isolate autotransplantation. Dr. Freeman is widely recognized for his contributions to therapeutic endoscopy, education and mentoring, training numerous specialists now leading in the field. His work has earned him numerous prestigious awards, including the Master Endoscopy in 2012, the American Pancreatic Association Lifetime Achievement Award of 2018, and the ASGE Rudolf Schindler Award in 2024. He has authored over 250 peer-reviewed articles and 30 textbook chapters, with landmark publications on ERCP complications, acute and chronic pancreatitis, and necrotizing pancreatitis. His research and clinical interests center on pancreatic and biliary disorders, particularly interventional endoscopy. Welcome, Dr. Freeman.
Well, hello and welcome, and thanks to Jenny for that very gracious introduction, and thank you to the National Pancreas Foundation for inviting me to give this talk, and we'll hope that you will enjoy it. It's Chronic Pancreatitis in 2025, patient-centered approach to actual patients that we've had the privilege to take care of. I just want to say I have no conflict of interest whatsoever, and all the pictures and references to individual patients are with the patients or their parents' specific consent and encouragement. They're very happy to share their stories. So I think the best treatment for individual pancreas patients really depends on a number of things. Multidisciplinary team, first and foremost. Have a plan ABC all the way through Z. There's a lot of, especially in procedural medicine, well, they'll do this. And then, oh, well, that didn't work. And you need to think what's going to happen next and what are all the aspects. Incorporate data and guidelines, but remember, having participated in many randomized controlled trials, my perspective is that They're important, but they're often colored by who gets into the study, particularly in chronic pancreatitis. They often exclude patients with comorbidity, extreme age. They include a very wide variety of etiologies and morphology, which you will see in these patients. And often in the US, at least, patients are treated outside studies primarily, unless they're viewed as marginal and, well, let's send them to the university for a study because we don't want to take care of that. And I mean, it's just, I think, a reality. Realize that evolving therapies may render all the data you're looking at obsolete because things change, especially in the endoscopic field, rather rapidly. Individualized therapy to the patient, and that's the concept of personalized medicine. So this is going to be a case series. First patient I saw about 2 years ago, 43-year-old male with chronic kidney disease, stage 5, on dialysis, awaiting renal transplant. And they always do a CT scan. They do pre-clearance for every organ system, and was referred to our pancreas clinic because of this rather giant stone on CT scan in the head of the pancreas. So just with that information, I'm going to ask you the same questions on most of these cases. And since it's not a live audience interaction, I'll just let you think about what you might think is most appropriate, and I'll tell you what we think it is. So what is the best therapy for this patient? Should we do ERCP, try to get that stone out? Should we do extracorporeal shockwave, lithotripsy to break it up? Surgery, drainage, partial resection, or total pancreatectomy, or medical therapy? And the key here is, as always, what are the symptoms? Well, it turns out patient has no pain whatsoever, but has full-on exocrine pancreatic insufficiency with a very low fecal elastase. So the treatment for this patient is pancreatic enzyme replacement therapy, nutrition, vitamin levels, etc., but don't touch this. Can't touch this. Case 2. And this is one that I added last year to the NPF Fellows course to bring out a different side of chronic pancreatitis. 63-year-old man referred to the University of Minnesota Pancreas Clinic as a third opinion for idiopathic recurrent acute progressing to chronic pancreatitis. Was previously healthy, not a smoker or drinker, 3-year history of symptoms, idiopathic recurrent acute pancreatitis, 3 years, cholecystectomy for gallbladder sludge, supposedly normal MRCP endoscopic ultrasound, and even had ERCP elsewhere with biliary and pancreatic sphincterotomy. But then he started to lose weight and have pain. 2 months prior, there was an outside repeat ERCP, which I didn't have access to, but then the patient sought a third opinion to consider surgery or endoscopy. So just to point out, he'd had an MRCP, and I'm trusting you can see my pointer. But this is the bile duct, and 3 months prior had an irregular enlarged pancreatic duct. But 1 month prior, they repeated the MRCP, and now he has a pancreatic duct stricture with a dilated upstream irregular pancreatic duct. And the consult was not urgent. This gentleman just walked into the office expecting further management. So we have to be thinking outside the usual box. What is the next step? Endoscopic ultrasound, repeat ERCP. Now, mind you, he's not had your basic CT abdomen pelvis. Or should he be sent for surgery, consult for a drainage operation? Now, obviously, there are other choices, but I bring this out because you don't ever want to skip the basics. And MRI is great, but it mostly focuses on ducts and does not show calcifications. And even more importantly, so we sent him for a CT scan of the chest, abdomen, pelvis, and here, that's his duodenum. Here in the head of his pancreas is a mass. And a speck of calcium, but a mass. And in his lung, he has multiple pulmonary nodules. And unfortunately, what this is you might suspect with a mass and weight loss is now pancreatic cancer. Furthermore, it's metastatic to the lungs. And we did then do an endoscopic ultrasound with biopsy. So this brings out a couple of points. Don't skip the basics. And when when the trajectory changes for a patient with chronic pancreatitis, look into other developments such as pancreatic cancer. Now, this patient actually survived for 1.5 years after the diagnosis of widely metastatic pancreatic cancer, and he was a poster child for current palliative therapy. He had biliary obstruction, did a metal biliary stent. He had pancreatic duct obstruction with pancreatitis, a parallel metal pancreatic stent here. And so he did not have to have endless stent changes. And then he developed gastric outlet obstruction. So we put in a duodenal stent. He had excellent quality of life till the last months, actually traveled internationally. He was quite a prominent figure in his industry. And then he went to hospice care and passed away at home with his family by his side. Risk of cancer with chronic pancreatitis. It's increased somewhat in some conditions, not as much in minimal change pancreatitis. I always ask patients at the end of every visit, are there any concerns that we haven't addressed or that are in the back of your mind? And one of the commonest ones that comes up, even with minimal change chronic pancreatitis, is this going to turn into cancer? Am I at risk for cancer? And it's an important thing to address. It's increased, but probably mildly in minimal change, and in PRSS1 hereditary early onset calcific is quite elevated. So the problem is it's very difficult to screen for or detect. And in general, we recommend investigating if there's any change in status. And that's what happened with this gentleman. Okay, case 3, 55-year-old male with intractably painful chronic pancreatitis. He lives 400 miles away from the Twin Cities. He was a smoker and heavy drinker, and now he's an insulin-dependent diabetic. Now, that is absolutely critical and often not paid attention to by gastroenterologists as much as we want, because presence or absence of diabetes really does influence therapy. First of all, ERCP, this gentleman has a pancreas that is just packed with stones from head till tail. This is it's basically all duct there. It looks like the gland is replaced by calcium, but a little hard to see here, but this is a thin-walled pancreas with a duct packed with stones all the way to the tail where there's a little pseudocyst. So what about ERCP? Possible, but probably 4 or 5 trips from 400 miles each way. Extraportal shock wave, well, what are you going to target here? You've got stones from head to tail. Surgery, drainage, Pusto or Fry. We do Fry procedures, which involves coring out the head and draining the body tail with a limb of bowel. Partial resection, well, which part are you going to take out? And then total pancreatectomy with islet autotransplant. First of all, with insulin, there are no islets to autotransplant. It's brutal diabetes. It's a big operation and unnecessary here. Medical is not working. He's already tried it. So to me, this and our team, and we meet every Wednesday to review these patients before embarking on a course of therapy with, I'll show you our team later. We thought the best option for him was to do drainage operation. And this is Dr. Greg Bielman, who is a champion of chronic and benign pancreas surgery, was surgical director of our entire surgical chronic pancreatitis program. And this is a slide from him for this patient. These are all these aren't composite cases. These are actual details and images. This is his pancreatic duct that has been split open like a banana peel with the banana removed, which is the stones, wide open from head to tail and a loop of bowel brought in, but also coring out the head. It's called a Fry procedure. And we thought, you know, one and done, the patient did not have to come back for repeated procedures. Okay, case 4, shifting gears a bit. And this is a blog that is public. So I have used, this is quotes from the blog approved by the patient's family. And this patient, this was just from January this year. Patient was only 10 months old when he cried out with excruciating pain, had frequent unexpected pancreatitis attacks. Testing revealed he had the same pathogenic PRSS1 mutation as his father and other family members. Mother said it got to the point where he was losing weight, couldn't get him to gain weight. Quality of life was so poor, we struggled to get him out of the house. He went to a children's hospital in a different state. Pancreatic duct had enlarged to 11.5 millimeters, which is huge. I'll show you the images. So he's 4 years, 7 months old. He's underweight for age. What should we do? ERCP with sphincterotomy dilate stent. He has a huge pancreatic duct here. This is 11 millimeters is about 5 times normal size for his age. And it's enlarged and stretched up, dilated all the way to the very ampulla. This is his gallbladder. So ERCP was sphincterotomy, dilate and stent his pancreas. Is that temporizing or is that going to be repetitive destination therapy? Because I've seen this done in patients like this. Do we do a drainage operation? He has a duct that's well big enough to just do exactly what we did in the last patient. Or should he have total pancreatectomy, islet autotransplant? And I'll just tell you what happened to him at the other hospital. They did a ERCP balloon dilated his pancreatic duct and put a rigid straight stent in here. As a sideline, I 20 years ago developed soft flexible stents with a small company because there's a risk of injuring pancreases with standard stents, which are still the majority that are used. No conflict of interest. I just developed them and they're pretty widely used. We use them a lot, and you'll see why. Day after the stent was placed, Warren experienced what Christy called the worst pain I've ever seen in him. He was in the hospital another week or two. They sent him home, but he got readmitted to a local pediatric hospital. And what the CT showed was that stent had actually perforated the genu of the pancreas, which is the neck, where the pancreas takes a right-hand turn. The stent is sticking through the side of the pancreas, and all of this is necrosis of the tissues around the pancreas. So it's pretty severe. The stent was perforating the pancreatic duct. So he got transferred to our center, and we're very integrated. Adult and peds GI were one combined service between adult interventional and pediatric pancreatology and associated disciplines. So we consulted and clear what was going on, had to get that stent out. There's a leak here from the duct where the stent had perforated it. And then we put in some of these soft, flexible stents to, as you can see, conform to the shape of the duct and drain all the juice and close the leak. And that got him towards the right track, but he had to be on NG tube for 3 months. Well, I think you can see where we're headed with this. Endoscopic therapy is rarely a good long-term option for stricturing disease in kids with hereditary disease. It's temporizing. This, unfortunately, was setback, but got him through it, and he had a total pancreatectomy and islet autotransplant. Just to remind you, that involves no immunosuppression, got his own islet cells back, and this is him now. No insulin, his hemoglobin A1C is normal. He's not diabetic and he's on no insulin. He basically takes handful of enzymes with every meal and lives a pretty normal life. And it really is nothing else you can do. We'll get into why not to do drainage operations on non-diabetic kids, especially with hereditary disease. What is TPIAT, as we call it? It involves removing the gray portion, which is gallbladder, bile duct, duodenum, pancreas, and spleen. So you lose a lot, but they reconnect it, reconnect everything, take the islets that are purified in our islet lab, put them back into the portal vein, and they seed the liver. And because it's the same circulation as the pancreas, they work. And you get alpha and beta cells, so you get counter-regulatory hormone glucagon as well as insulin. So that's very important to avoid highs and lows with blood sugar. This was developed at the University of Minnesota in 1977. They've done over 850 cases, adult and pediatric. Dr. Bellin, you may know, is our lead clinical scientist. She's a pediatric endocrinologist by background, but has devoted her career to this and is now actually president of the American Pancreatic Association as a pancreatologist, which is unprecedented for an endocrinologist. And she's devoted her career to doing exquisite research. Here is a study that our group published 14 years ago. In children, their baseline quality of life, which is mental and physical component is so poor prior to TPIT. This is miserable. And then after 2 years, they're actually right in the 50th percentile for the kids next to them in the classroom. So they normalize their quality of life. Kids do remarkably well with this. So who did her surgery was Dr. Srinath Chinnakotla, one of my own. He's one of my personal heroes, along with Dr. Greg Bielman and many others, Dr. Bellin. He is exquisitely devoted to his patients, and he has published the leading papers, highest impact papers on TPIAT so far. Annals of Surgery, 3 papers in the Annals of Surgery on quality of life, factors predicting outcome, and particularly in children. The person who invented TPIAT was this brilliant, kind, and rather, how can I say it, dynamic and unusual gentleman, David Sutherland. Did the world's first TPIAT in 1977 at the University of Minnesota. Lovely man, passed away just this past year. He really launched this whole idea in the program, and this is a picture of our in-person group from 15 years ago. We meet every Wednesday. This is Dr. Sutherland and various surgeons, me, Dr. Bellin, nurse coordinators, Ty Dunn, great surgeon. And this was the early meeting. 10 years later, our group had expanded, and notice it's equal peds adult, all meet together every week. Now it's all Zoom, so we actually have this many people meet actually every week on Zoom and go through all our chronic pancreatitis patients that are on questionable for which way to go. We can't present all of them that we treat endoscopically or medically. We'd never end the meeting. But for really, borderline. Dr. Bellin has devoted her career to this and just finished, and it's being published in Gastroenterology, a huge multi-center study that included the 12 leading centers in the USA that do TPIAT, prospective NIH-funded outcomes, which are very good, and I hope will change perception, because there are many, many centers that don't either do or incorporate TPIAT, and we're hoping that this paper will have some impact. Okay, case 5, identical twins with PRSS1. We have many, many hereditary pancreatitis patients in our region, particularly PRSS1. There's a lot of kindreds in this area, and we see patients from all over the country, but these patients happen to live in our area. First came to us in 2015, 10 years ago, referred by Mayo Clinic. This 17-year-old has the classic pathogenic mutation, referred from Mayo for TPIAT by their pediatric service. At that time, she had 3 large stones in her main pancreatic duct, but she'd had isolated episodes since age 5, feels fine in between with no pain. She's not diabetic, which is critical, but she's a high school athlete and very physically active. And interestingly, when I polled the audience at the NPF, many voters thought, and this, as you know, is experts, fellows, and patients, as the NPF is a patient-generated and run organization. When most people thought she should have TPIAT. But this is not a great time to have a huge operation, adolescent woman, very physically active. So we went through this list as a variety of choices from the audience, but this was the dawn of really advanced endoscopic therapy for pancreatic stones. We went over this with the patient and family. And we said, well, we can get those stones out endoscopically. It may take a few procedures, and she does not have intractable pain. Even if she did, might improve. So these are some of the stones, huge stones in the head. We did then do extracorporeal shockwave, which we don't routinely do now, but when it didn't do much for the stones, just smudged them up a bit. So this was the dawn of digital pancreatoscopy. We're actually ERCP putting a tiny four-way steerable digital scope in. Here's the look at the stones with a scope in the duct and a little blasting bug zapper called electrohydraulic lithotripsy. And in the first section, we were able to pretty much clear the duct of all major fragments. Well, fast forward to 10 years, and I verified this in April at our NPF meeting. She's completely symptom-free for 10 years, age 27. I had to bring her back in, find her and bring her back in to make sure she really was okay and not building up a whole lot more stones. So the interesting thing is, of course, she has an identical twin who had a pusto at age 6, another part of the country. She got acutely ill a couple of years ago, required 2 weeks of NG feeding, and we had to do spyglass electrohydraulic lithotripsy to treat a residual stone. Now is doing well. But this shows that she'd had her pancreas filleted open. This is air in the pancreas, collapsed pancreatic duct, and there's a stone down in the head with a pseudocyst. So I'm always cautious about making, proclamations of how great patients are doing without checking with them for the update, because it can almost jinx them. So I called them the night before. This is our patient who got endoscopic therapy, or twin who had surgical. This is their cousin. This is the text. We're doing wonderful, leading happy lives. We're so good, working out every day and eating lots of lean whole foods. Hope you're doing well. And I love this. Good luck at your presentation tomorrow. You're going to do amazing. They're giving me encouragement. One of them is a personal trainer, and the other is I'm not exactly sure what she does, but they're living nice lives and they have all their organs intact. So when that's possible, that is a great option, I think, for hereditary disease. They don't need surgery. Now, first question, because I've heard a lot of experts say, well, if it's PRSS1, it's going to progress. They need their pancreas out. Do genetics determine type of interventions? I really don't think so. I think you have to dial to the individual patient. And why not do drainage surgery, which is recommended by most guidelines, over endoscopic therapy, over endoscopic therapy? Why not drainage surgery? Well, there's a good reason. I'll show you. First of all, I think the assumption that surgical therapy is better than endoscopic therapy is based mostly on very old studies. One of them was 22 years ago, and the other was 18 years ago. They were done in Europe. Almost all middle-aged alcoholic smokers with very large duct disease, which is actually the minority of chronic pancreatitis, that none of them used even close to optimal therapy for endoscopic treatment. They didn't target, because they didn't know how to do duct clearance then, or aggressive stricture resolution. And they don't include marginal surgical candidates, which in most practices is the majority. Might have portal hypertension, heart disease, or something. So the third study that is used to make guidelines is a very well done study from the brilliant Dutch pancreatitis study group, published 5 years ago. And they, in Netherlands, they're able to get the majority of the country involved. But they're all large duct disease patients. They were randomized to upfront drainage surgery or ERCP, ESWL, but no spyglass or digital pancreatoscopy to clear stones, with a step-up approach. If that failed, then they switched to surgery. And it's worth pointing out that only 62% of the endoscopic first arm got complete stone clearance. And if you look at the overall group, the group that looked to do best was early surgery. And this is sustained pain score over 18 months. The endoscopic group without duct clearance didn't do near as well. But if you look at the subgroup, step-up group, post-hoc analysis showed that complete duct clearance by endoscopy SWAL was associated with outcome as good as the early surgery group. And look at this. This is complete duct clearance, and this is surgery. So I think if you get complete duct clearance, and it's reasonable, and your center can do that, which I might say huge part of what we do. We send many patients to surgery if we don't think we're going to be able to accomplish that in a reasonable time, or with that patient's anatomy, or we clear their duct and they fail. But then if the duct is totally clear and they're still in pain, then drainage surgery wouldn't have worked either, most likely. And then it's a question of TPIAT if that's appropriate. So I think it's really important to pay attention to this complete duct clearance. One of the other factors to consider for surgical drainage is that it impairs islet yield should the patient fail to respond, which is about half of patients long-term after drainage surgery. And if they're a candidate for TPIAT, prior drainage surgery severely impairs islet yield. ERCP, on the other hand, does not. And this was shown in a spin-off of the post study, which Melina Bellin is PI of, and the multi-center group. So you don't burn bridges for TPIAT with ERCP unless you cause a severe complication, which can happen, almost happened in our 5-year-old, but fortunately, thankfully, was able to recover. But drainage surgery is irrevocable. So this is why for hereditary and other etiologies of chronic panc, in younger patients who are non-diabetic, we really try to avoid drainage operations because of that fact that we went over. And the other flip side is endoscopic therapy done really optimally may be very effective for pancreatic stone disease. You've seen the two identical twins. The one only had endoscopic therapy. He's doing great 10 years later. And she could still, if things get worse, I mean, she has no symptoms now, and that's pretty exceptional, but she's still eligible for TPIAT. Now, TPIAT is applicable to a very, very small minority of patients with chronic panc, but I liken it to liver transplant. How many patients with liver disease get a liver transplant? Maybe 1 in 500 to 1,000. TPIAT, it's not that rare, but it should, I think, be incorporated into thinking. Quickly, I don't want to get too technical, but one of the issues with pancreatic stone disease is the traditional approach to break up stones is extracorporeal, but the emerging and I think really definitive way is putting a tiny scope in the pancreas. And ESWL is a separate anesthesia. You only do a single stone, not widely available. You don't need endoscopic expertise, but you need expertise at ESWL. We have one of our, Dr. Trigger Nathan, our GI interventional and pancreatology guru, that's his actual name, does our own S-wall, but we use it primarily for inaccessible stones or giant obstructing stones where you won't even get the scope in. But we primarily do pancreatoscopy, lithotripsy. And as you saw in the video, you can typically break up all the stones from head to tail. It is a very technically challenging procedure, but it's like anything. Do a lot of it, get the hang of. And I was just going to end on a sort of the frontiers that are being pushed in endoscopic therapy. And again, it's not static, unlike drainage surgery hasn't changed in 50 years. This changes yearly. But this is a 70-year-old retired MD who's very active. She plays all kinds of sports, golf, non-diabetic. She had a Whipple 15 years ago for pancreatic neuroendocrine tumor. And as will happen with a normal pancreas, developed recurrent acute pancreatitis, although she was well in between. And this is not something you can treat by standard ERCP because it's a very long limb going up there to find. You can't find the pancreas even if you can get a scope there usually. But we did a endoscopic ultrasound rendezvous to access the duct and did a dilation stent. But I won't go into what rendezvous is, but it was actually invented by my colleague, Sean Mallory, who did this. And it worked. I mean, the stents fell out, she did well, but then she came back a couple of years later with more intractable pain and a new pancreatic duct stone. And you can see this white blob here is pancreatic stone. The only part of her pancreas remaining is the tail and the body. The head is gone. This stone is in the duct, blocking the duct with an enlarged duct. It's right up against the stomach. Well, it's not in this picture, but it's close. And Dr. Mallory did a procedure that we reported that's very tricky, but can be done. Punctured a fistula from the stomach into the pancreas. Here's injecting contrast into the pancreatic duct with a stone. Here is totally obstructed anastomosis. Placed tiny little stents through the stomach, through the pancreas, coming out beyond the stone into the bowel limb, which is great for drainage, but how do you treat the stone? And we reported this novel technique using tiny wires, tiny catheters, and tiny stents to avoid trauma. So this is what pancreaticogastrostomy looks like. Tiny target, angioplasty balloon, backwards 3 French stents. And you can see here, this is contrast in the stomach, the stent going from the stomach through the stomach wall into the pancreas and hooking with a pigtail in there to hang it in place. But then once that's matured, what we did is actually take the spy scope and put it through the stomach along next to the stents into the pancreatic duct. And as you see in the video fragment, the stones push them through. And thankfully, that was about 4 years ago. And she's done terrifically well. So one would say, why not operate? Well, surgery here would be a total pancreatectomy, splenectomy, maybe a drainage operation, but and you know, that would have been the backup, but probably not necessary here. And this is an example of frontiers where we are always moving the needle, trying to always move the needle. So to summarize, multidisciplinary team, plan A, B, C through Z, incorporate data and guidelines, but RCTs of interventions only apply to the patients and procedures in those studies, and they can be outdated, they can be suboptimal in one arm, or state of the art, but they're always dependent on who gets in the study. And realize that evolving therapies may make any conclusions of those studies obsolete. And the real way to get best outcomes is spend time with the patients, individualized therapy, and this is what we call personalized medicine. So I just want to end with a photo allegory. We were in Panama in a treetop observatory, and sitting there was a 3-toed sloth, and this was a slow-moving event, but he woke up and very slowly decided to go out on a limb, as they say. And this, you don't need a high-speed shutter stop for this. Reaching over to a branch, pulling himself over, ending up hanging on a little limb to get to his favorite fruit. And this is a bit like developing advanced therapy. Sometimes end up hanging out on a limb, but if the fruit is worth it and you don't fall off, it lets you expand therapies. So this is a picture my daughter took in New York at the John Lennon Memorial. Imagine, you can only imagine improved therapies, ideal treatment for that patient. And any one patient is not like all the other patients. So thanks for your attention. I'm sure I went way over time, but hopefully some valuable points.